Good day. My name is Hector Lopez, and this is my end-of-term presentation for my Kinesiology 4380 online course or exercise science internship for the spring 22 semester at the University of Texas at Rio Grande Valley. My presentation is on using exercise physiology for cardiac rehabilitation. Hope you enjoy. The United States Public Health Service states cardiac rehabilitation services as a widespread, long-term program that involves education, counseling, medical evaluation, cardiac risk factor modification, and prescribed exercise. Cardiac rehabilitation is a methodically designed program that includes nutritional education, physical activity, lifestyle modification, and weight management to aid people with cardiovascular diseases to live healthier lives. Cardiac rehabilitation is currently supported in patients after coronary stent placement, acute coronary syndrome, valve surgery, coronary artery bypass grafting, and stable chronic systolic heart failure. Also for patients with decreased ventricular ejection fraction, compensated heart failure, and after cardiac transplantation. Measurement methodologies. Cardiac rehabilitation progression is based on clinical performance and quality measures. A 2020 report by the American College of Cardiology, American Heart Association Task Force on Performance Measures developed a general cardiac rehabilitation measure set that has 18 measures. These measures are distributed in 4 qualitative groups. There are 13 performance measures, 4 quality measures, 1 structural measure, and 2 rehabilitation performance measures. These measures are divided by performance and quality measure, numbers, measure title, care setting, attribution, and measure domain. Although the measures are presented together, their application can be applied individually. When applying any measure involving a patient's input, it is important to take the patient's education under consideration. Benefits of cardiac rehabilitation. The benefits of cardiac rehabilitation are seen on patients with coronary artery disease, coronary artery bypass grafting, valvular heart disease, heart failure, and cardiac transplant. In patients with coronary artery disease, most of the patients are referred to cardiac rehabilitation centers, are diagnosed with coronary artery disease. Cardiac rehabilitation exercise training with coronary artery disease enhances the quality of life and improves exercise tolerance in the patient along with a decrease in angina, ischemia, subsequent hospitalizations, and mortality. Numerous meta-analyses have shown the cardiac rehabilitation decreases mortality in patients with coronary artery disease. A meta-analysis did show many studies of numerous randomized clinical trials dating over the last 60 years that included over 14,000 patients showed that cardiac rehabilitation patients, when compared to a non-exercise control group, reduced the cardiovascular mortality in patients with cardiovascular disease. Cardiac rehabilitation also reduces the potential for cardiac events, mortality, and hospital readmissions after coronary artery bypass grafting. Coronary artery bypass grafting is usually chosen for patients with arteriosclerosis at the advanced stage, like those with heavy calcification in the coronary arteries or stark multilevel lacerations when association with percutaneous coronary intervention. An observational study composed of over 800 patients following a coronary artery bypass grafting saw a decrease of over 10% in absolute risk, reduction of all-cause mortality, and over 45% relative risk reduction. Currently, the evidence that supports cardiac rehabilitation for patients with coronary artery disease is well established. However, the data for patients after valve surgery is limited. In a 2017 study that observed over 30 randomized transcatheter aortic valve replacement patients and showed that in over 8 weeks of supervised resistance and endurance exercise training or standard care, the VO2 max increased over 3.5 milliliters per minute per kilogram in the exercise group when compared to the control group. The same study showed that the quality of life and muscle strength improved noticeably in the exercise trained group when compared to the control group. In 2014, Medicare introduced coverage of cardiac rehabilitation for patients with heart failure with reduced ejection fraction. With this new implementation, patients are now eligible for coverage if they are present stable heart failure with a left ventricular ejection fraction under 35%. In multiple randomized trial studies, patients saw an estimated 45% decrease in mortality with 38 decrease in hospital admissions or readmission in the exercise testing group. Medicare used the result of multiple studies to approve cardiac rehabilitation reimbursement. This trial experimented over 2,000 patients in standard therapy or exercise training. The results showed that exercise training decreased the hospitalization of all-cause mortality by over 10%. Patients with cardiac transplants make up a small portion of the referrals for cardiac rehabilitation. The patients referred because of this issue are usually intensely deconditioned because of their lengthy hospital stay, their unforgiving heart failure from before the transplant, and the possible side effect of immunologic therapies. Randomized trials done on cardiac transplant patients have been done and show that cardiac rehabilitation causes a 49% increase in VO2 max at the 6-month mark, with exercise training when compared to an 18% increase in the control group. Preliminary assessment. When starting a cardiac rehabilitation program, it is important to follow the protocols that have been established by physicians. Exercise training programs should be personalized for each patient. The patient's personalized prescribed exercise program should be based on comorbidities, physical evaluations, assessment results, patient and program goals, and risk stratification. The fundamental components of the program should be based on the intensity of the exercises, training sessions frequency, progression, modalities, and the duration of the exercises at hand. Cardiac rehabilitation programs should be preceded by contraindication screenings to exercise, which include a physical examination, echocardiograph, medical history, and resting electrocardiogram. The physical examination should evaluate the cardiovascular procedure wound, cognitive aptitude, neuromuscular and orthopedic status, and cardiopulmonary systems. The medical history should evaluate the cardiovascular diagnoses, previous cardiovascular procedures, symptoms of cardiovascular disease, comorbidities, cardiovascular risk profile, educational preferences and barriers, and medications. The exercises must follow an acceptable development for tissue and organ adaptation. The individualization of the exercise prescription during phase 1 is important because the specificity of the exercises prescribed directly impacts the total time of the exercise sessions. This is because the intensification in the exercise load causes a physiological imbalance, trailed by the adaptation phase, which the result is performance improvement. Phase 1. In phase 1 of cardiac rehabilitation is done in an in-hospital setting where they are supervised and monitored for their vital signs. Patients in phase 1 therapy are encouraged to take walks in and around their rooms and hospital floors, do range of motion exercises, and sit in a chair. The intensity of exercises is for the individual to be below 13 in the table of perceived effort. The phase 1 cardiac rehabilitation protocol is divided into 3 levels, 1, 2, and 3. Level 1 is the day of admission, in which the patient is on complete bed rest. It focuses on relaxation, breathing exercises, and active range of motion, exercises to the hip and knee. During days 1 and 2 of level 2, the patient is at partial bed rest and focuses on sitting, relaxation, breathing exercises, and active range of motion exercises, like finger and wrist movements and ankle-foot movements. Level 3, which are days 3 and 5, the patient is now up and about. This level stops the relaxation and focuses on progressing level 2 exercises to 10 repetitions. And the patient can walk within the room 3 times a day, and when standing, the upper limb flexion is exercised. Level 3A focuses on the patient standing and walking with lower limb flexion. It also allows the patient to stride and stand with hip and knee flexion and walk outside the room 3 times a day. Level 3B focuses on the band standing, elbow circling, trunk bending. It also allows the patient to walk outside the room with arm swings and climb 1 flight of steps. Phase 2. Once the patient has completed phase 1 of the rehabilitation program, they may advance into phase 2. Phase 2 is done in an early outpatient setting where they are supervised and monitored for their vital signs. After being discharged from the hospital, the patients can partake in monitored exercise programs through which their blood pressure, heart rate, symptoms, and heart rhythm are supervised. This rehabilitation program requires a total of 24 sessions divided into a 2 sessions per week, 12-week comprehensive program with gradual approved treadmill exercise training being the foundation. This part of the rehabilitation allows the patient to begin a range of physical activity that allows the heart rate to reach a certain level. The process for the patients entering and going through this phase in cardiac rehabilitation must be progressive and monitored. This type of exercise is usually on a treadmill, bicycle, rowing machine, or walking. The frequency is generally set at 3 days per week and advances to 4 days a week. When a day is added, that extra day is generally done at home without any sort of monitoring from the clinician. The duration of the time exercises sessions usually begin at 15 minutes of constant exercise, headed by 5 to 10 minutes of warm-up and trailed by 5 to 10 minutes of cool-down exercises. Phase 3. Phase 3 cardiac rehabilitation program is done after completing the previous 2 phases. Patients who complete phase 2 of the cardiac rehabilitation program are regularly encouraged to take part in phase 3. The goal of phase 3 cardiac rehabilitation is to help patients with long-term commitment to consistent exercise and other behavioral lifestyle changes introduced during phase 2 cardiac rehabilitation. Phase 3 cardiac rehabilitation programs are usually supervised by healthcare providers, but it is not needed. The supervision level is lesser than that of phase 2, which results in a lower cost of the program. Patients in phase 3 cardiac rehabilitation are encouraged to intensify their strength training and exercise duration while the emphasis remains on cardiorespiratory exercises. Multiple studies have been done to evaluate the impact of their cardiac rehabilitation on individuals that have or suffer from cardiovascular diseases. Most participants complete a 12-week phase 3 cardiac rehabilitation program. All the phases in cardiac rehabilitation programs include behavioral health, counseling, nutritional education, medication management, smoking cessation, stretching, yoga or Pilates, and stress management sessions. Barriers to participation in cardiac rehabilitation. When identifying cardiac rehabilitation barriers, they were divided in 3 major phases: referral, enrollment, and adherence and completion. The cardiac referral phase showed that at the provider level, the lack of cardiac rehabilitation knowledge, lack of endorsement, and language proficiency in the way of discussing with the patients. At the system level, the barriers presented are the lack of referral endorsement and language proficiency in an automatic referral method. At the individual level, the cardiac referral phase showed the lack of cardiac rehabilitation knowledge, which is the most common identified barrier at this phase, and language proficiency to be the most impactful barriers. The cardiac enrollment phase showed that at provider level, the lack of cardiac rehabilitation knowledge was the major barrier. At the system level, the major barrier was a practical or logistical one. The individual level presented the most barriers at this phase, having age, culture, lack of family support, language, religion, knowledge, interests, beliefs, psychological status, practicality, logistically, and socioeconomic status all have an impact in the enrollment for cardiac rehabilitation. The cardiac adherence and completion phase showed that at provider level, the lack of knowledge of cardiac rehabilitation and language presented the major barriers. At the system level, the major barrier was practical and logistical, like transportation issues, weather, location, and time constraints. The individual level presented the most barriers at this phase, having culture, language, religion, knowledge, interests, beliefs, psychological status, practicality, logistically, social and economic status, and individual perceptions like the lack of motivation, comfortability level with exercise sessions, vulnerability, and hopelessness all have an impact in the adherence and completion for cardiac rehabilitation. Based cardiac rehabilitation programs. Persistence training has been suggested as a method to complement endurance aerobic training. It is recommended to implement this type of exercise 2 to 3 times a week. The intensity of this training is to be set at the patient's 1 repetition maximum, considering the working muscle size and the relation among the resting period and the period of muscle contraction. A proper advancement in resistance training is characterized by a 3-step model. Initially, an instruction phase is to be performed. This is to be done with a very low resistance, slow exercises, pending the patient's confidence with the movements throughout the course of the exercise. Following this phase is the endurance resistance training. This phase could be started at the patient's 30 to 40% of 1 repetition maximum test, somewhere in the range of 12 to 25 repetitions. The final step in this 3-step model is the introduction to strength training phase. This phase is to present strength training with greater intensity. This phase could be started at the patient's 40 to 60% of a 1 repetition maximum test, somewhere in the range of 10 to 15 repetitions. Constant aerobic exercise training is usually the central element of the exercise prescriptions for patients with heart failure. Aerobic exercises include walking, rowing, jogging, and cycling. The lower range is the starting point, should be between 40 to 50% of the peak VO2, and the target intensity at the higher range should be reached gradually at 50 to 80% of the patient's peak VO2. The ideal frequency of aerobic exercise training should be 3 to 5 sessions per week. These objectives should be progressively reached, and the less conditions patients may begin with 10 to 20 minute sessions to 2 to 3 times per week. The advancement in aerobic exercise training program should be initially seen in the duration of exercise sessions, followed by the frequency and then the intensity of the exercises. In patients with heart failure, interval training sessions can be effective and take shape in the form of cycling, swimming, walking, rowing, and other types of exercises depending on the patient's abilities and characteristics. The typical method to assess the patient's exercise intensity is a symptom-controlled cardiopulmonary exercise test. The exercise intensity may be arranged in relation to the patient's VO2 reserve, the anaerobic threshold, and or the peak VO2. Normally, the intensity target is to be considered between 40 to 80% of the patient's peak VO2. The ideal frequency of aerobic exercise training should be 3 to 5 sessions per week. These sessions should be 20 to 60 minutes in duration. Unfortunately, the medical professional that I reached out to did not reply or answer to any of my calls or emails. I understand the point deduction that comes through with it as it was stated in the syllabus. This documentary was made within the context of this course, the Kinesiology 4380 online course at the University of Texas, Rio Grande Valley. This was due April 22nd of the year 2022. Thank you for listening.